Acute kidney injury is a medical emergency characterized by a rapid and often reversible decline in kidney function, occurring over a few hours to a few days. This sudden deterioration in glomerular filtration leads to several imbalances in the body. Among the main effects, a metabolic acidosis due to the accumulation of acids that the kidneys fail to eliminate, leading to a decrease in blood pH. A hyperkalemia results from potassium buildup in the blood, which can severely affect heart function. And fluid overload leads to excessive water retention, causing generalized edema. The diagnosis of acute kidney injury relies on several clinical and biological elements that help quickly identify this severe condition. The urine output disturbance is an important alert signal. Anuria, which is the near total absence of urine production, is defined as a volume of less than 50 milliliters over a 12-hour period, while oliguria, characterized by urine production of less than 0.5 milliliters per kilogram per hour for at least 6 hours, is another sign of concern. AKI can cause an acute uremic syndrome, which includes several symptoms. The fluid overload can be of two types. First, intracellular fluid retention may lead to hyponatremia or low sodium in the blood, causing serious neurological disturbances such as seizures or coma, etc. And the extracellular fluid retention can result in edema and increased blood pressure or even acute pulmonary edema, which can impair breathing. The mineral disturbances such as hyperphosphatemia or excessive phosphate in the blood, as well as low serum albumin levels or hypoalbuminemia, and finally some digestive disturbances such as nausea, vomiting, and sometimes gastrointestinal bleeding often complicate the clinical picture. To confirm that kidney failure is acute, these elements help distinguish acute kidney injury from other chronic or transient renal conditions. A rapid increase in creatinine indicates a rapid deterioration in kidney function, which is characteristic of acute kidney injury. A creatinine level that remains stable or increases gradually could suggest a chronic renal disease instead. In acute kidney injury, the kidneys typically have a normal size, which can be confirmed via renal ultrasound. Bilateral renal atrophy, on the other hand, is more common in chronic kidney diseases and indicates a long-term loss of kidney function. Anemia, although frequent in chronic kidney diseases due to prolonged kidney dysfunction, is not a typical sign of acute kidney injury. A rapid decline in kidney function does not have time to cause significant anemia. In acute kidney injury, calcium levels or calcemia often remain normal, unlike in chronic kidney disease, where calcium metabolism disorders such as hyperkalemia or hypocalcemia can develop over a long period. A normal calcium level is further evidence against chronic kidney disease. It is also important to differentiate between anuria and acute urinary retention. In anuria, the formation of urine by the kidneys is completely stopped. This suggests renal failure, where the kidneys no longer function properly to eliminate waste and regulate the water-sodium balance. In the acute urinary retention, the cessation of urine production is due to a bladder emptying defect, not a renal failure. The problem lies in urinary tract obstruction or an inability of the bladder to empty properly, which prevents urine from being excreted despite normal production. Therefore, it is crucial to systematically check for a bladder distension, known as globus vesicalis, in any patient with oligonuria. When managing acute kidney injury, there are some signs of severity that may indicate a life-threatening risk to the patient. These signs concern various body systems and reflect serious imbalances. Water and sodium retention can manifest as hypertension or acute pulmonary edema, severe complications related to fluid overload. A chest X-ray is essential to check for this, which can rapidly affect the patient's prognosis. A high potassium level, called hyperkalemia, is common in AK and can cause cardiac arrhythmias. An electrocardiogram can detect abnormalities such as peaked T waves or prolonged PR intervals. The accumulation of non-volatile acids, which are acids produced by cellular metabolism that cannot be eliminated by the lungs, often leads to metabolic acidosis, characterized by rapid and deep breathing to compensate for excess acidity in the blood. The buildup of azotemic wastes, such as urea, can cause neurological disturbances like confusion, seizures, or coma, indicating an uremic syndrome. From a hematological perspective, a failure in platelet aggregation can lead to spontaneous bleeding, seen as bruises, gum bleeding, or gastrointestinal bleeding.